So let's talk about platelet disorders. So platelets are small, clear, very important enucleate, irregularly shaped cell fragments produced by larger precursor cells called as megakaryocytes. Platelets are produced during hematopoiesis in a sub-process called as thrombopoiesis. Thrombopoiesis is stimulated and regulated by thrombopoietin hormone TPO. The average lifespan of platelets, which everybody knows, is 7 to 10 days. Normal platelet count is 1.5 to 4.5 lakh per microliters. So abnormalities of platelets. Disorders of platelets are known as thrombocytopathy and is broadly divided into abnormal number of platelets and abnormal platelet function. Abnormal number of platelets is divided into thrombocytopenia, which is reduced platelet count, thrombocytosis, which is increased platelet count. Abnormal platelet function include inherited disorders of platelet function and acquired disorders of platelet function. The steps of thrombopoiesis include in bone marrow, the hematopoietic stem cell gets converted into common myeloid progenitor cells, which then converted into promegakaryocytes, which gets further converted into megakaryocytes, which then releases platelets into the cytoplasm. Now, this is a very important chart from Harrison. So, if platelet count is less than 1.5 lakh, then you look at hemoglobin and WBC count, which is normal. Then look at the peripheral smear. If there is normal RBC morphology, platelets are normal or increased in size, you'll have to consider drug-induced thrombocytopenia, infection-induced thrombocytopenia, idiopathic immune thrombocytopenia, and congenital thrombocytopenia. If the peripheral smear shows fragmented red blood cells, then it goes towards microangiopathic hemolytic anemias like DIC and TTP, thrombocytopenic purpura, thrombotic thrombocytopenic purpura. If the platelet counts are abnormal, then we look at if the hemoglobin and the WBC count is abnormal, then we'll go for bone marrow straight away. And if in the peripheral smear platelets are clumped, you have to redraw the sample in sodium citrate bulb or heparin bulb. So brushing through on very important points considering acquired platelet disorders. Mainly they are due to infections, drugs, vitamin deficiency, radiotherapy, and bone marrow infiltration. The characteristic feature is there is decreased marrow megakaryocytes and reduced peripheral platelet retic count. Treatment: treat the underlying cause and platelet transfusion. Recombinant TPO agents can be given. Coming to increased platelet destruction, it is mainly of two types: immune mediated and non-immune mediated. Immune mediated is immune thrombocytopenic purpura and post-transfusion purpura. Non-immune, it is TTP, hemolytic uremic syndrome, HIT, that is heparin-induced thrombocytopenia, and drug-induced and hypersplenism. Coming to the very important points of ITP, it is characterized by immune-mediated destruction of platelets and inhibition of platelet release from megakaryocytes. It is mainly of two types: primary, that is idiopathic; secondary, associated with underlying disorders like SLE, infections like HIV, and hepatitis C. New classification, it depends on the duration. So newly diagnosed is from diagnosis up to 3 months. Persistent is from 3 to 12 months, and chronic, it is lasting more than 12 months. So coming to the pathophysiology, there is antiplatelet antibodies frequently directed at platelet glycoproteins 2A3B, 2B9, and 1A2A, and 5 form an antigen antibody complex which is destroyed in the spleen. Clinical features are mucocutaneous bleeding, ecchymosis, petechiae, oral mucosa bleeding, GI bleeding, and heavy menstrual bleeding. Laboratory findings include platelet count and large platelets in peripheral smear. Treatment mainly consists of steroids, that is prednisolone, 1 mg per kg. IVIG are given at the rate of 1 to 2 gram per kg given over 5 days, and RHOD immunoglobulin 75 microgram per kg for RH positive. Severe ITP, high dose of glucocorticoids with IVIG and additional immunosuppressive agents like rituximab. In case of chronic ITP, you can give azathioprine and TPO receptor agonist like romiplastin, eltrombopag, and the ultimate treatment is splenectomy. So coming to thrombotic thrombocytopenic purpura, it is characterized by microangiopathic hemolytic anemia, thrombocytopenia, renal failure, neurologic findings and fever. Idiopathic TTP and inherited TTP are related to the deficiency of or antibodies to metalloprotease ADAM-S13, which claims the von Willebrand factor. Idiopathic ITP is more common in women than in men and in patients with HIV and also in case of pregnant women. HUS, it is characterized by acute renal failure, microangiopathic hemolytic anemia, and thrombocytopenia. It is usually preceded by an infection or episode of diarrhea, and it is usually found in pediatric age group. Atypical HUS is due to genetic defects that result in chronic complement activation. Primarily supportive. The treatment is usually supportive. Uh, Eculizumab monoclonal antibody against C5 has efficacy and improves renal function. That is a very important MCQ. Followed by patients with atypical HUS are usually treated with plasma exchange. Coming to heparin-induced thrombocytopenia, it is complication of exposure to heparin that can be low molecular weight heparin or unfractioned heparin. It occurs due to autoantibody against endogenous platelet factor 4 in a complex with heparin. Antibody activates platelets, leads to venous and arterial thrombosis. Heparin-induced thrombocytopenia is usually of two types, type 1 and type 2. So heparin-induced thrombocytopenia type 1, it is non-immune mediated platelet aggregation. It occurs within 2 days of exposure to heparin. It is mild in nature and there is no need to stop heparin in case of HIT 1. HIT 2 is due to autoantibodies to platelet factor 4 complex to heparin. Heparin has to be stopped. Diagnosis is by detecting antibodies by ELISA. Treatment is stop heparin. Fondaparinux can be given. Anticoagulation with danaperoid, lepidudin, and ergatroban, that is newer anticoagulants, can be started. So this is the table from Harrison which shows drugs which cause thrombocytopenia. Coming through very commonly used drugs, and which is important, is acetaminophen, amiodarone, amlodipine, ampicillin, carbamazepine, ceftriaxone, ciproflox, diazepam, furosemide, gold, haloperidol, heparin, brufen, that is ibuprofen, loraz, that is lorazepam, naproxen, penicillin, phenytoin, piperacillin, quinine, very important, quinidine, rantax, that is ranitidine, which we commonly use, then trimethoprim sulfamethoxazole, vancomycin. So these are very important drugs which we use very commonly can cause thrombocytopenia. MCQs are asked in this, that's why I am covering this chart. Thrombocytosis is defined as platelet count more than 4.5 lakhs. Causes of thrombocytosis are primary thrombocytosis, myeloproliferative neoplasms, CML, polycythemia vera, essential thrombocythemia, myelofibrosis, secondary or reactive thrombocytosis, blood loss, infections, neoplasms, postsplenectomy, and in case of iron deficient state. Platelet dysfunction, thrombasthenia, acquired thromboasthenia is seen in uremia, paraproteinemia, drugs like aspirin, that is acetyl salicylic acid, ticlopidin, NSAIDs, clopidogrel, tricyclic antidepressants, and myeloproliferative disorders. Hereditary thromboasthenia is seen in two syndromes, Glanzmann's thromboasthenia, that is defect in aggregation receptors GP2B3A, and Bernard-Solier syndrome, defect in adhesion receptor. First, Glanzmann is aggregation receptors and Bernard-Solier is for adhesion receptors GP1B9, and storage pool disorders. These two are very important as MCQs usually asked in the exam.